Okay, good morning, good day, good night, dear friends, dear colleagues. The SG webinar now will start. The session is Advanced Diagnostic in Gynecological Endocrinology. Today we have two speakers, and after two speakers, we have discussions. I'm Professor Yuan, come from Beijing, China. I'm the chief editor of Department of Gynecological Endocrinology, Beijing Obstetricians and Gynecology Hospital, Capital Medical University. Today, I'm very honored to be the chair for the session. The two important speakers. One is Professor Wouter, Froyman. His topic is ultrasound diagnosis in ovarian etiology of abnormal uterine bleeding. Professor Wouter is MD, PhD. He's a consultant in obstetrics and gynecology at the University Hospital of Leuven, Belgium, specializing in gynecological ultrasound and minimal invasive surgery. He got her PhD in 2019, became associate professor in 2020, and serves on the IOTA study steering committee. Now, Professor Wouter, please give your presentation. Thank you.
Thank you, Professor Yuan, for your kind introduction. I hope you can hear me now.
Yes.
Okay, thank you. So we talk about ultrasound diagnosis in ovarian pathology that could cause abnormal uterine bleeding. So first of all, we have to distinguish possible incidental findings of an axial mass in patients that present with abnormal bleeding. And we can have patients where the lesion is really the cause of the abnormal uterine bleeding. And we know that some of the causes will be related to the tube, and then you will have anatomical causes of bleeding. If the lesion is located in the ovary, you can have hormonal causes of abnormal bleeding. So the bleeding can be functional or endocrinological. You can have infectious causes of bleeding. Endometriosis can be related to bleeding or neoplasia. So when we describe lesions on the adnexus, so the tube or the ovary, we will always use the standardized definitions and terminology as published by the IOTA group about 25 years ago now. So the standardized terms and definitions. We want to distinguish between things that are functional and which should perhaps not be treated invasively, can be treated conservatively, or can be expected to resolve spontaneously, and other findings that might be neoplastic, like benign neoplastic tumors. But these patients can be managed by general gynecologists. If you have a lesion that is suspicious to be malignant, there the patient will be benefiting from referral to a gynecological oncologist, and there the management will be also different, whether it's a borderline, an invasive tumor, or a secondary metastasis from another origin towards the ovary. So we want to have a proper assessment of these potential subtypes of pathologies. And let's start with some functional cysts that can be related to patients that present with abnormal bleeding. So maybe the patient has anovulation, anovulatory cycles, and there you can have a persistent follicle or a follicular cyst. So these will present as unilocular smooth-walled cyst with an anechogenic content, as you know, with very limited vascularity and without any solid tissue. So this is a very common finding for all gynecologists, so follicular cysts. If the patient had an ovulation with some hemorrhage, you can have a corpus luteal cyst, as you all know, with a thicker wall and the very typical ring of fire and the hemorrhagic content. So these are easy for most of us to identify. And sometimes when there's more hemorrhage, when it's a hemorrhagic cyst, you see the blood clots. And if you push with your ultrasound probe, you will see it moves like in a jelly wave fashion. Sometimes the clot will be retracting and get more and more dense. And now and then we get patients referred for a lesion that is suspected to be containing a solid component. But in fact, if you push with your ultrasound probe, you will see that this component is moving and that you can clearly see this is not a solid component, but a blood clot, which is retracting. So you have to use ultrasound in a dynamic way, and you have to push gently with the probe on the lesion to see this kind of findings. So these are all functional changes. We know that PCOS has one of the key features, the ovary to be polycystic ovarian in morphology. So ultrasound there has also a very important role. So you can do manual counting of the follicles, or you can have automatic follicle counting, as you can see here, to have your patients diagnosed with PCOM. So these are all rather functional endocrinological things that can be present in patients that present with abnormal bleeding. Patients can also have an anatomical cause of bleeding if there is some pathology in the tube or the salpinx. The tube can be dilated because of the presence of water or fluids, or it can be blood. Then we talk about hematosalpinx, as you know, or the presence of an infection and pelvic inflammatory disease. You can have pus inside the tube when there is an abscess, a tubo-ovarian abscess. And if you have fluid in the tube, there can be retrograde, or there can be evacuation of this fluid towards the uterine cavity. So patients that have hydrosalpinx or a hematosalpinx often present as well with irregular discharge that can be blood, bleeding discharge, if the blood evacuates through the tube towards the uterus. So if it's a hydrosalpinx, you know the wall is thin. You can have pseudosepta. A pyosalpinx, you will have more mixed or ground glass content, a more dense content. The wall will be thicker. You will have more vascularity, and it will be painful. And in hematosalpinx, you might have ground glass content inside the tube, and that's often associated to endometriosis. It's important, if you look at the tube and you consider that there might be a septum, that you go through the volume in a cine, as you see here in a clip. And then you can see that if there's an interruption of this septum, then it's a pseudoseptum, which is very typical, as you know, for the presence of tubal pathology. So tubal pathology can be the cause of abnormal bleeding in patients. So what about the neoplastic findings? So we talked about the functional cyst, the tubal pathology. What about the real tumors? So we know some will be benign, some can be malignant. How do we classify them? Well, we know from a recent consensus paper endorsed by also ESGE and ESGO that we should apply the IOTA two-step strategy to stratify patients in risk groups. So the two steps consist of first the application of benign descriptors, and then in the second step, the use of the up-next model in the so-called two-step strategy. So this consensus has been published and is accessible through the different journals that have published it. So I can really recommend you to read this paper because it also consists chapters on the different types of ultrasound findings on different types of ovarian tumors. So what are these two steps? The first step is the application of the benign descriptors. These are unilocular cysts that are easy to be recognized and that are very suggestive for the presence of a benign entity, like here on the left, a unilocular tumor with a ground glass content. If it's less than 10 centimeters, it's very suggestive for the presence of an endometrioma. Most of you know that. Second, a unilocular tumor with a mixed content. So you see here a mixed echogenicity, and you see acoustic shadows. If it's less than 10 centimeters, this is suggested for the presence of a dermoid cyst or a mature teratoma. Then the third one is the unilocular anechogenic tumor, so a very hypo or anechogenic content. Regular walls, also less than 10 centimeters, is suggested for the presence of a serous cystadenoma. And then the last group are the remaining unilocular tumors with a regular wall less than 10 centimeters, like for instance, a serous or a mucinous, cystadenoma. So these are unilocular types of cysts that are less than 10 centimeters. So you can easily recognize these types of descriptors. And if you can apply them, you know that the patient has most probably a benign lesion. So what if you cannot apply the benign descriptors? So we know that the benign descriptors can be applied in about 40% of all the patients. If you cannot apply the benign descriptors, we will recommend the use of the IOTA ADNEX model. So ADNEX is a mathematical model. It is you cannot calculate it in your head. You need a formula. So you can have it as software embedded in the ultrasound machine. There are also applications for the smartphone. And ADNEX will not only distinguish benign from malignant, but ADNEX will also distinguish between subtypes of malignant tumors like borderline, like stage 1 invasive ovarian tumor, stage 2 to 4 ovarian tumor, or a secondary metastasis from another origin that has spread towards the ovary. So ADNEX works with some input variables, some features that you have to assess. And first of all, we have three clinical features. We have the age of the patient, the type of center, and then the biomarker C125. So you don't need C125 to calculate the risk with ADNEX, but if you have a tumor that is more suggestive for malignancy, if you add C125 there, you will have a better prediction of the subtype of a malignant tumor. So we can recommend C125 to predict the subtype of a malignant tumor. So we have these three clinical variables, and then there's 6 ultrasound variables, which are quite easy to be obtained. I will show you. So this is the ADNEX model embedded in an ultrasound machine. So we know we have the age of the patient, the type of center, and then we measure the largest dimension of the cyst. So we have to go in all scanning planes. We go for the largest dimension. And when we scan the patient, we can measure it. And when we measure it, the value will automatically be given as input in the model. So first, the largest dimension of the mass, and then second is the largest dimension of the largest solid component. So you see here, there's solid tissue. There are in fact 2 papillations in this tumor. And here we measure the largest diameter of the largest solid component. So this is the second measurement. And then we have some questions. Having more than 10 locules? No. 2 papillations, shadows, and no ascites. So we have quite easy questions to be answered, and then you can calculate the risk of malignancy. And when the risk is 10% or more, we will suggest that you should discuss the case at least with a gynecological oncologist, because then there's an increased risk of a malignant tumor. This is another example. This is a patient that is postmenopausal, and she has a unilocular solid tumor with a papillation which is quite big, with quite some vascularity inside. So here we can also apply ADNEX. So the age was 69. We have a largest dimension of almost 9 centimeters, and the largest solid component, this papillation that measured almost 5 centimeters. We did not have acoustic shadows and no ascites. And then C125 is available, was 25, but as said, it's not necessary to have C125 to calculate the risk of malignancy. So we measure here the tumor size and the size of the largest component, and we add the other questions here. And in the ultrasound software in the machine, we can calculate that this patient has a risk of malignancy of about 83%, which is way above the cutoff of 10%. So this is clearly an indication of a malignant tumor. So this is without C125. So we scan the patient, and usually we don't have the biomarker. So here we already know it is suggestive for a malignant tumor. So if you look at the subtypes of malignancy, you can see here the predictions. Stage 2 to 4 ovarian cancer has the highest risk, almost 50% risk. And this is an increase of the risk of 3.5 factors. So it's a big relative increase for our patients. So this risk in an advanced stage ovarian cancer. So here we will add C125, which was 25. You can see the risk is still very high, and the risk prediction is changing. So now you see that the highest risk is for a stage 1 tumor over here, which is also now the highest relative risk. So this is the orange bar, as you can see here. So we add C125, and we see that the model helps us to predict the subtype of tumor. So now with C125, Upnext tells us, think about a primary ovarian cancer, stage 1. And the patient was operated, and indeed the final histology report was positive for a stage 1 endometrioid invasive ovarian cancer. So this is about adnexal lesions in general, but I would like to really focus as well in this second part of my lecture on some specific malignant lesions that are really associated to abnormal uterine bleeding. So we know that we have different types of ovarian tumors. We have tumors from the epithelium, so the epithelial tumors like serous tumors. We have germ cell tumors, stromal tumors, and secondary metastases. These are the largest groups of ovarian tumors. And for those who are interested, there's a very nice series available in the journal Ultrasound in Obstetrics and Gynecology. And the series are called Imaging in Gynecological Disease. And there you can find really different publications on different subtypes of adnexal masses. So if you have an adnexal mass with a particular appearance, and you think about some potential different pathologies, you can always look up these papers because they really show very nicely how different types of ovarian pathology looks like on ultrasound. So let's start with epithelial tumors. So some of them might be associated to abnormal bleeding, especially if you have tumors from the tube. If you have invasive tumors from the tube, there might be one of the symptoms that can be presented to patients is the presence of abnormal bleeding. So we know that serous tumors in patients will present as with abdominal distension because there's very early metastasis. Patients have ascites, have omental cake, so they will have pain. And in about 6.5%, the patients will present with abnormal bleeding in serous tumors. On ultrasound, they usually appear as multilocular solid or solid tumor with a quite high vascularity, so color score 3 and 4. And very often, patients will present with ascites. But tubal cancer, I mean, it is in the tube and it can cause shedding and bleeding, is very much related to abnormal uterine bleeding. So more than 80% of the tubal cancers are serous in pathology. And because of the shape of the tube, you will see that first it starts to grow in the wall of the tube as some kind of papillation, some kind of papillary projection. But then it starts to expand and it will take more and more of the content of the tube. But as the tube is tubular in appearance, you will have this so-called sausage shape morphology in a patient that has tubal cancer. And often you can also distinguish from this tumor still the adjacent ovary. So if you see a tubular mass with a lot of vascularity and adjacent to it, you see the ovary. If you, of course, ruled out an ectopic pregnancy, you will think about a possible tubal cancer. So remember, tubal or tubular shape and a lot of vascularity. So this is an example of a patient that presented with postmenopausal bleeding. You can see here that you have two structures that are slightly mobile, one from the other. On the left side, we see the ovary with some residues of follicles. And then next to it, you see this tubular shaped mass with a quite high color score. So this was a tubal cancer presenting in a patient presenting with abnormal uterine bleeding. So this was a macroscopic specimen. So you see here the mass inside the tube. Here you see the fimbriae and separate to it, the ovary. Another cancer from the epithelial group, which is associated to abnormal bleeding, are the endometrioid tumors, because ovarian endometrioid cancers are associated to endometrial hyperplasia and also atypia and also endometrial cancer, as you know. So endometrioid cancers of the ovary are associated to abnormal bleeding. They present as rather large masses, often unilateral in appearance, and they have a multilocular solid or solid appearance. So either they are multilocular solid or they are completely solid in appearance. Some of the endometrioid cancers originate from endometriosis. If they do not originate from endometriosis. We talk about some coccate appearance. So you see here, you have a confluence of septa coming together, and then you have this large solid component like completely circumvented by cystic areas. And this is a so-called coccate appearance, like a concentric solid tumor in the center. And then around it, you see septa with cystic areas around the solid components. So this is a feature which has been associated to endometrioid cancers. If the endometrioid cancer is related to endometriosis, so we know that an endometrioma can be precursor of endometrioid cancer, or also clear cell cancer, then we see that in the mass we have the papillation. So then we don't see the coccate appearance, but then we see often some papillary projections in the wall of the tumor. Which other ovarian tumors are the cause of abnormal bleeding? So we talked about epithelial tumors, serous tumors, tubal cancers, endometrioid tumors. Now we move to the stromal tumors. So we have stromal tumors that are causing abnormal bleeding. So this is the classification of the sex cord stromal tumors. And I will focus on the Sertoli Leydig cell group of tumors and the granulosa cell tumors. So the granulosa cell tumors are about 1% of all ovarian tumors, and the adult type is the majority, so 95%. The remainder are the juvenile type. They are typically unilateral in appearance, and very typically they are large. The average diameter is about 10 centimeters. And you can see them at any age. So you can see them in reproductive ages, but also in post-menopausal patients. So they present often because of the size with hemoperitoneum. The patient has a fastly growing mass which can rupture, and that can cause bleeding. And so in 1 of 10 cases, the patient presents with acute bleeding intra-abdominally because of rupture of the tumor. Luckily, the majority of the patients will present in an early stage, so stage 1. And a stage is the most important prognostic factor. The prognosis is, in general, very positive. However, the patient can have a late recurrence. As you know, that granulosa cell tumors, they can secrete estradiol. So they are estrogenic, and they will cause endometrial hyperplasia, and in the minority of the cases, even atypia and endometrial cancer. So there's a correlation between granulosa cell tumors and endometrial hyperplasia and endometrial cancer. The biomarkers for this tumor are typically AMH and inhibin. A minority of the patients can also have androgenic symptoms due to androgen production of the tumor, but majority will present with estrogenic features. On ultrasound, there's a very typical pattern in granulosa cell tumors, and that's the presence of Swiss cheese. So the Swiss cheese pattern, so the cheese with holes inside, is a typical finding for a granulosa cell tumor. But granulosa cell tumors might also be completely solid in appearance. So these are more examples of granulosa cell tumors with the Swiss cheese pattern in patients that often also present with a thickened endometrium. This is another example of a granulosa cell tumor. So you see a multilocular solid tumor with a lot of cystic areas. Is very suggestive for the presence of a granulosa cell tumor. And then the other group that I want to discuss, and I'm almost at the end of my lecture, are the stromal tumors, the Sertoli Leydig cell tumors. So they are also a minority of ovarian tumors, less than 1%. And the majority of the patients will present with endocrine symptoms like oligoamenorrhea or irregular menstruations. And then there are androgenic symptoms like hirsutism, lowering of the voice, and balding. The patients will have typically a unilateral lesion, and they will not have a solid or a Swiss cheese appearance. They will have solid tumors that are rather small. So granulosa was large, average 10 centimeters with the Swiss cheese appearance. Leydig cell tumors are rather small solid tumors. but they can be well vascularized. And patients are median about 33 years old. And then one case is, to conclude, a patient 58 years was referred by the endocrinologist because she had an increased testosterone level. She presented with hirsutism and also lowering of the voice, and the MRI of the adrenal glands was negative. And here you can see that we have in the ovary a rather small solid tumor, and around it you can still see some normal stroma. So the darker area is a normal ovarian stroma, and centrally you have a more hyperechogenic solid tumor inside the ovary, which is not so big. And with the color Doppler, you see it's quite vascularized. So if you see a solid, more hyperechogenic nodule in the ovary with quite some vascularity in patients with endocrinological symptoms, think about the potential presence of a Leydig cell tumor. This was a specimen at macroscopy and after transecting. So here you see the normal stroma, and centrally in the ovary you see the Leydig cell tumor. So I will conclude here. So if you look at the adnexs in patients that present with abnormal bleeding, think also about standardized definitions, standardized terminology to describe your findings. So many patients that have abnormal bleeding will be found to have functional cysts, so cysts that can still disappear spontaneously, or they can have benign tubal pathology like a hydrosalpinx or a hematosalpinx. So very often it's benign. If it's not functional, then you can classify most tumors, any tumors with the benign descriptors as benign, or even upper cysts less than 10 centimeters, suggested of an endometrioma, a cystadenoma, or a dermoid cyst. And if you cannot apply these benign descriptors, then adnex will be your best test to distinguish between benign and malignant. And we know that adnex can also suggest the subtype of malignant tumor. So this is the so-called two-step strategy, first the benign descriptors and then adnex. So in patients with abnormal bleeding, you can find any type of adnexal lesion, but some can also be the cause. And remember that serous ovarian cancer can be the cause of abnormal bleeding, especially if it's located in the tube. Also, endometrioid cancer is related to endometrial hyperplasia, can present with abnormal bleeding. And then two tumors that are secreting estradiol or testosterone are granulosa cell tumors and Leydig cell tumors, respectively. So if you have patients with abnormal cycle, abnormal bleeding, think about the presence of this type of tumor when you see an abnormal ovary. Thank you so much for your attention.
Oh, thank you very much for Professor Froyman's excellent and practical lecture. After second lecture, we will have discussion. You can take a rest.
Thank you. A pleasure.
Now, introduce the second speaker. The second speaker is Professor Nicola Pluchino. His topical is saliva-based mRNA signature for early diagnosis of endometriosis. Nicola, MD, PhD, serves as head of reproductive medicine and gynecological endocrinology at Lausanne University Hospital. Dr. Pluchino gets her PhD in reproductive medicine and has extensive experience in minimal invasive and robotic surgery, gynecological endocrinology, and infertility treatments. Now, we please Nicola give you a lecture. Thank you.
Thank you for thank you for the kind introduction, and It's always a pleasure to be part of this webinar. So in the next 20 minutes, I will share with you some new insight, what we call the new revolution into the endometriosis diagnosis, and some practical aspect for daily life in our clinical practice, at least from my perspective and from the Swiss experience with endometriosis diagnosis. And in order to introduce the topic of today, I would like just to remind to the audience that endometriosis is a very common, complex, it's a heterogeneous condition that is associated with a delayed diagnosis. And in 2020, a very elegant review will summarize at least 4 reasons for this difficulty in diagnosis endometriosis. And we know as a gynecologist the symptoms of this disease are not specific, that there is a stigma, symptoms normalization in many families and women with an history of endometriosis. There is a sort of lack of awareness, but biologically speaking, in 2020, there was no specific marker for this disease. And 2 years later, the guidelines provided by the ASHRE did not help the clinician more than what was expected. So, as you probably know, in case of suspicious of endometriosis, in case of symptoms associated with endometriosis, ASHRE suggests doing a clinical examination and imaging. Ultrasound or MRI scan in order to provide diagnosis. But if this seems to be quite easy, we know in our daily practice that the situation is much more complicated. And at least the guidelines also aware the clinician that even in case of negative finding for endometriosis, the imaging, the clinician does not have to exclude the presence of endometriosis. And this statement is a sort of frustration, I would say, in our clinical practice, because we are not able to give certitude, any certitude of our patient. And even if the imaging is negative and we can suggest any empirical treatment to our patient, well, at some point we can also estimate a sort of over-treatment and over-diagnosis of endometriosis because we have not any proven symptoms and sign of clearly endometriosis diagnosis in our patient. And at the end, patients that are not responsive to treatment or they want to do something more, they go to laparoscopy diagnosis. And if it's the guideline in 2022, this is what we have in our clinical practice. What we every day we can see that our patient has a delay of between 7 to 10 years in average in diagnosis, and that mostly of them, at least 40% of patients, they have to do more than 5 consultations in order to get diagnosis. And you can see 25% of patients goes through laparoscopy. And when you are in the laparoscopy and you see a stage 4 endometriosis, and you have to do maybe also laparoscopic treatment of endometriosis, despite the surgical technique and despite the surgeon ego, in my perspective, this is a failure in our medical practice, at least in endometriosis management. And the other point that is so important in our clinical practice to remember is that in the majority of the cases, so at least 62% of women symptoms starts very early when they are adolescent or when they are between the age of 20 and 25. So this is something important to know, but what is also important to mention, again, there is so many data out there that support that this is not just a matter of pain, because if symptoms starts early, there are also many consequences on a personal level, on a relationship level, and on a social level that are impacted by a delayed diagnosis of endometriosis through the different milestones phases of women grow from adolescence to adult and to pre-menopause. So we have to do more. We have to do something different in order to get the diagnosis of endometriosis early. This is, we know, a urgent need in our clinical practice. And the opportunity came from macro RNA. And I would like just to remember, for people that are not familiar with epigenetics, that microRNA are non-coding RNA that are very well conserved, and they played a major role in the regulation of transcription between gene to protein. And in the majority of the cases, microRNA block the transcription for the RNA to the protein. And to date, there are more than 2,600 microRNA that has been described. And in case of endometriosis, there are enough data that support that microRNA play a major role in the different mechanisms associated to the physiopathology of the disease, from inflammation to cell proliferation to progesterone resistance and to estrogen dominance. But at the same time, in the last 10 years, microRNA has been also investigated as a potential biomarker of the disease. And it's my pleasure today to introduce this concept of microRNA in the saliva. And doing that, I would like to share one of the seminal paper into evaluation of microRNA in endometriosis patient in order to build up a signature for optimized diagnosis. And this is the paper that has been published 3 years ago already by the group of Sofiane Benifala in Paris. That is a study that it's a prospective core trial that investigated the microRNA content and expression of 200 patients, 200 women with symptoms suggestive of endometriosis, and that they were in pain at the enrollment. And the majority of that pain was associated with dysmenorrhea. And that studies is innovative from two perspectives. Was innovative because they quantified the microRNA in the saliva through a next generation sequencing platform. And I will show in a few seconds. They also used a special protocol for statistical analysis and modeling with the use of the artificial intelligence. And as I said, the objective of that studies was to analyze the current microRNA expression transcriptome into the saliva, was to understand and differentiate patients with and without of endometriosis, and to develop then a diagnostic signature of endometriosis. And in order to better understand the results of that study, I would like just to show you the characteristic of the patient, of those 200 patients that has been enrolled. So 100%, so all the population was symptomatic. All the population have dysmenorrhea. So they all have symptoms associated with a potential diagnosis of endometriosis. Some of them, they have other gynecological condition. So this is not normal, would say, daily life in a gynecological department. fibroma, cystadenoma, teratoma. Some of them, they have typically additional pain symptoms like sciatica, like lower back pain, right shoulder pain, all symptoms that are suggestive for endometriosis. And you see that at the end, all patient goes through imaging or laparoscopy. That was the gold standard to make diagnosis of endometriosis. And you see that the group with was diagnosis with endometriosis, they had in 50% of the cases stage 1, 2 disease, and in the 40% of cases they had stage 3 and 4. So this represent various phenotype of endometriosis, what we have in our current practice. And I would like just to briefly show you the technique that is behind this diagnostics tool, because make the difference in comparison to all the other microRNA evaluation that has been done in the past. So just to give you the complexity of this evaluation, I would like just to remind that in each sample, or in each 2 milliliter saliva sample, this has been evaluated between 13 to 40 million reads of microRNA, and together with a multiple filter and quantification, at least 190 million of sequences have been analyzed or are currently analyzed in 2 milliliter of saliva in order to identify at least 2,561 microRNA that are known to be expressed in the human body, and specifically in the saliva. And this specific analysis, together combined with protocol or artificial intelligence, give as results of a panel of 109 microRNA that are differentially expressed in control group, so patient with symptoms associated with endometriosis but without the disease, and symptomatic patient with endometriosis, and with a sensitivity of 96% and a specificity of 100%. This, was a very successful trial that has been already validated in another publication, at least the interim data that has been published in 2023 on the New England Journal Evidence. You see that in this interim data analysis of external cohort, the sensitivity the specificity of this 109 saliva signature remain very high, 96%, the sensitivity and the specificity 95%, supporting that this test still highly performant in the diagnosis of endometriosis, and also confirming the stability and the reproducibility of this investigation, because sample have been provided by at least 15 center in endometriosis center in France. And just to give you an example of how this test is powerful, we had the chance in Switzerland to use that test since 2023, that has been already commercialized in a different European country. And you see that on the left side of the screen here, you see that the results of the test, that is it is in French, of course, but just the results. The test is normal or abnormal, so meaning that the presence or absence of endometriosis is based on this molecular analysis. And this is the case of a patient of 30 years old, symptomatic, with symptoms then suggesting for endometriosis. And you can see on the right side of the screen the laparoscopy evaluation that is being performed in that patient, because there were there was a desire for spontaneous conception were after at least 2 years of infertility. And you can see here that the left uterosacral ligament, and this is here that's the uterus, and that's the peritoneal. You can see that the lesion, the superficial lesion of endometriosis, something that is not possible to reach by the ultrasound or by the MRI scan. And I would like to see to show you again that lesion properly with a zoom. You see that only maybe skilled surgeon or surgeon that are familiar with the diagnosis of endometriosis are able to reach out that lesion. And this is also a reason to share that why the sensitivity and the specificity also of diagnostics laparoscopy is not 100%. And you see that from the study of Wykes in 2024, sensitivity of diagnostic laparoscopy is 94% and the specificity is 79%, even with histological confirmation. But if you don't trust me, I show you the results of the histological confirmation after the excision of that lesion that I showed you before. So you see that we have here the results from the test that show the presence of endometrioma, of the endometriosis. We have the laparoscopic confirmation of 1 centimeter at least on the left uterosacral ligament superficial endometriosis, and there is here on the right side of the screen you see the confirmation of the presence of endometriosis at the histological level. That is in French, that confirm the presence of endometriosis. So this powerful tool gives us also the opportunity to discuss a new diagnostic algorithm for our patient in order to improve certitude in our patient, in order to improve the quality of treatment of our patient. So if we start from signs and symptoms associated with a risk of diagnosis of endometriosis, of course, we follow the ASHRAE guidelines that support the use of clinical examination, ultrasound, or MRI scan to make diagnosis of endometriosis. And then we can have two different scenarios. The scenario where we can have the diagnosis of endometrioma or deep lesion, and this is quite common if those lesions, those phenotypes of endometriosis are present. Of course, the ultrasound and MRI scan are highly sensitive and specific to make the proper diagnosis. But in case of normal or not fully clear diagnosis of endometriosis using ultrasound or MRI scan, we can propose the analysis, the marker RNA saliva test, in order to have at least 96%, 95% chance to make the proper diagnosis. That's one possible pathway. Another possible pathway to start an empirical medical treatment as suggested by the ASHRAE. And again, we can, if there are if the symptoms are improved by the medical treatment, or if they are not improved by medical treatment, we can again provide the test for the diagnosis of endometriosis in order to be really sure that we are not over diagnosis and we are not over treatment a patient that is not responsive because the patient has not endometriosis. But this is a tool that is, of course, based on the presence of symptoms for endometriosis, but they offer also the opportunity to look a different scenario, a different pathway also of a potential treatment. And this is, for example, the opportunity to identify a signature, not just for the presence of endometriosis, but in the signature for the presence of infertility associated with endometriosis. And this has been provided again by the same group it has been published last year, where they found 34 microRNA signature that are specific with the diagnosis of infertility associated with endometriosis. This is, of course, you can imagine that this, if validated, may have huge clinical impact on a daily management of a patient. But this is not just about the presence of the absence of the endometriosis, so able to make the diagnosis, but there are now also data that using this strategy, using these technologies, using this specific analysis through the artificial intelligence protocols, the same group was able to identify 89 microRNA signature that are specific for the diagnosis of peritoneal endometriosis. So what we can see at the ultrasound, what we can't see at the MRI scan with a good specificity. And that test is associated with a sensitivity of 91% to 10%, depending of the algorithm that has been selected, and a specificity over 95% to 10%, suggesting that, again, the performance is definitely better than any imaging that we have actually available, and maybe better than laparoscopy. The point is now is to use this tool also to answer more questions about endometriosis. And I would like just to share some of the ongoing trials that are now available using these technologies, this platform that is provided by a company in France. This is called Ziwick. And you see that there are ongoing multi-center validation for the diagnosis of endometriosis, but there's also ongoing trials to investigate the response to treatment. So to predict the response to treatment in our patient, the second most important question that we have to answer before doing any treatment in order to personalize treatment, hormonal treatment also to our patient. There are ongoing investigations on teenagers in order to optimize the diagnosis of endometriosis even earlier, at the beginning of symptoms, in order to reverse the pathway, the negative pathway of a delayed diagnosis, as I said before. There are now testing also other pathologies that can be associated with endometriosis. There are also common in the gynecological practice. And this technology can be also applied to other pathology. One of the ongoing trials is about ovarian cancer, and also to other fields of the medicine, like the neurology, that provide optimize diagnosis test for example, amyotrophic lateral sclerosis. So this is my conclusion. This test, the salivary microRNA test, function as a non-invasive diagnosis tool for endometriosis. And for the moment, the specificity and the sensitivity is more than 95%. And I remind you that is at least the specificity higher than diagnosis laparoscopy for superficial lesion. This test is intended to be a diagnostic tool. It's not a screening purpose. That's so important because the population has symptoms suggested for endometriosis. This is the population that has been studied. This is the population that is the target of this tool. And of course, external validation is still ongoing. And as I said in my presentation, this test has the potential for, I guess, for the first time in comparison to other biomarkers for endometriosis to address properly the gap between diagnosis of endometriosis and especially for preventing some of the most important consequences in our patients, so chronic pelvic pain and infertility associated with endometriosis, offering then new opportunity, a new different scenario of treatment. Thank you so much.
Okay, thank you very much for Professor Nicola. Excellent lecture. It's very interesting. Now the session is question and answer. First, we answer the questions from the audience. Now we can have two questions. The first is from Freddie Neptolin. His question is, I think the question maybe is to Professor Wouter. Yes, in situ tubal cancers are a major source of ovarian cancers. How early can these primary tumor cancers be detected? Can in situ versus invasive be determined? If so, what are the hallmarks of pre-invasive and worse invasive lesions?
Yeah, that's a good question. You have the type 1 and the type 2 ovarian cancers, and the type 1 develops from precursors like cystinomas and then borderlines that go into a malignancy. And then the type 2 are indeed often occurring from the tube. And then you have the stick lesions, so the intraepithelial lesions of the tube. But in fact, it's very hard to detect this type of tumor in early stages. So it's already difficult to detect a stage 1 ovarian cancer that originates from the tube. So it's even less possible to detect a precursor lesion, and an intraepithelial lesion is on ultrasound not possible to be seen. So, well, these are microscopic and millimetric abnormalities. So like a still or a stick lesion, you will never be able to detect that on ultrasound. The normal tube is not easily visible on ultrasound. And so ultrasound will not be possible with the current technologies to detect these precursor lesions or to make the difference between the non-invasive and the invasive tumors. So that's why ovarian cancer is so difficult to be detected on ultrasound in early stages, especially the type 2 that originates from the tube. The ones that originate from a cyst that is larger, more voluminous, you will more easily detect it. But these are also less aggressive in their evolution, and that's why they are often detected in early stages. So like the type 1 cancer, like the mucinous cystinocarcinomas, things like that, they are detected in early stages because they are obvious, they are voluminous. The type 2 cancers that originate from the tube are very small, and they start to shed, they start to disseminate, and they are not easy at all to be detected on ultrasound.
Okay, thank you. The next question. What's the cost of endo test? Are the specialists agree with it, please? I don't know. Yeah, maybe your question.
Yeah, it's my question. So I can answer just for the Switzerland market because I'm not aware about the price in other countries. So, but for Switzerland market, it's about 700 Swiss francs. So it's about 800, less than 800 euro. And there are, if you want, there are studies already that support that the cost, of course, is less. You can imagine, is less than provide and doing a laparoscopy in order to make the diagnosis. And if you combine this with the opportunity to perform an early diagnosis of endometriosis, especially avoiding multiple consultation, multiple ultrasound examination without any clear results. This is, of course, something that has quite a evident gain for the patient, for the global healthcare system.
Thank you. The next question I think also is for Nicola. Is it recommendable to make the saliva test at all women with dysmenorrhea?
At all, women with dysmenorrhea, yeah. That's that's probably what I recommend in case of, even if we follow the recommendation by the ASH guidelines. So clinical symptoms have to be properly recorded. Symptoms like pain and dysmenorrhea as properly investigated with imaging, like US or ultrasound or MRI. But in case of negative findings, so no clear diagnosis, of course, we have to do better. And what we have now to do better, that's the opportunity that currently we have to do better in our clinical practice. Also to answer properly to our patient. What I say, that's my perspective. My perspective when we say that primary dysmenorrhea, I don't believe to primary dysmenorrhea. I think that primary dysmenorrhea is just with our conclusion that we are not to make the proper diagnosis. So now, if we want to proper meet the patient needs, is to provide answer. Provide answer is endometriosis or the presence of the absence of endometriosis in our patient.
Thank you. The next question also is for Nicola. Can the endo test be used under ongoing hormone treatment or contraception? Thank you.
Yeah. What I can say that for the information that we have by the clinical studies that has been published, there is no influences by the use of hormonal treatment of the menstrual phases. So patient can provide and can do the test in each phase of the menstrual cycle, or even if they are under hormonal contraception. That's probably associated with, we are not evaluating just one market, but we are evaluating a signature of 109 microRNA. This is something that is different. So the influences with hormonal treatment may be different.
Okay, the next question also for Nicola. All patients with positive microRNA are candidate for surgery, or only when seeing big lesions in MRI or ultrasound?
That's the personalized care that have to be discussed with the patient. It depends of the situation, it depends of the reasons, it depends of the symptoms, it depends of the clinical situation, the clinical scenario. Is it for infertility? Is it for pain? Is it for just to give answer to the presence of questioning about dysmenorrhea? So in my perspective, is not just a way to push people to surgery. It's the opposite.
Thank you. The next question from Sano Delhi. The greetings from Kathmandu. Excellent presentation and updated information about endometriosis. Endometriosis is not a cancer, but a behavior as a cancer. Your comments?
My comments is that endometriosis is a very heterogeneous disease, and we are far from understanding this heterogeneous disease and the biology decision, and we are quite far away to understand the pain mechanism associated with endometriosis. But I think that this strategy, so going through next generation sequences, exploring microRNA, so exploring epigenetics of the disease, it's one tool that gives us much more information. This is not just about diagnosis, but just also, could be also informative for the physiopathology of the disease and also to understand, to clustering the disease. What we have now is to cluster the disease better. It's not just about three phenotypes, superficial, deep, or ovarian. We need more information, much more molecular information to clustering the disease properly and to inform properly the patient.
Thank you. Next question. The markers CA125 and the HE4, which one is more valuable to distinguish benign from malignant?
Ultrasound.
Yes.
Ultrasound.
That's and the correct answer. So ultrasound is always better. So if you compare the biomarkers alone and you compare them with ultrasound, ultrasound will always be better in performance to distinguish between benign and malignant. If you don't have ultrasound in a lower resource setting and you can do a lab test, then you can use biomarkers. CA125 will be the best for serous cancers and also the later stages, so has a quite higher sensitivity, but the specificity is not so good. So patients that have endometriosis or patients that have a PID or a patient that are pregnant or any other condition can increase CA125. So your specificity with CA125 is not so good. So if you have the combination of, the HE4 has a better specificity. So that's why the combination of the two, CA125 and HE4, is used in the ROMA test. So ROMA is better than doing nothing for diagnosis, but ultrasound models will be better. So ultrasound will be the best. And if you don't have the ultrasound, ROMA could be a good way to do something or to have a diagnosis, but ultrasound is better.
Agree with you. Okay, thank you. The next question concerns the saliva test for endometriosis. What about endometriosis and adenomyosis uteri?
Yeah. For the moment, the test doesn't distinguish between adenomyosis and endometriosis of the combination between them. We are at the very beginning of this informative tool, and the target and of the study at the beginning of the endo test course was to diagnose endometriosis. So the signature that is currently used, that is currently provided to patient, is just to diagnose endometriosis in symptomatic patient.
Thank you. The next question, the cost of saliva test. That's the cost of saliva examination. Similar question.
Yeah, seems I can answer worldwide because I guess each country has a different cost, and maybe there are reimbursement also processes that are ongoing from different medical health economy perspective for each country. So I can't answer properly. I have only the experience of my country.
Okay, thank you. The next question. The question for both speakers. Ovarian cancers are rarely diagnosed at stage 1. Do you think microRNA technology can be developed for early diagnosis of ovarian cancer?
There is some research on this as well. So for the microRNA, so there's already quite some publications available that show that there's a potential role of this tool as well for ovarian cancer. But often in ovarian cancer, there's a big difference if you look at the later stages versus benign. If you compare that to, for instance, borderline versus benign or stage 1 versus benign, so often these tests will have another performance depending on the stage of the tumor that you're testing. So the results will be more optimistic for later stage cancers versus benign compared to the limited tumors that are stage 1. And so for RNA, but also there are DNA tests already done on blood. So that test for chromosomal instability on cell-free DNA. And the findings are often the same, that if you look at advanced stage cancers versus benign, it seems to be promising. But if you look into detail in the early stages, and these are the ones that you want to detect to make a difference in the outcome, that the tests are less helpful. So at this moment, I'm not aware about one test that can replace ultrasound, but they are working on it, and maybe in the future there might be also these biomarkers available, maybe combined with ultrasounds. That could be a possible future application.
Okay, the next question from our president, Andrea Giannizzani. The question is, there are cases of primary dysmenorrhea where it is very difficult to achieve a diagnosis. Do you believe that Indu test should offer a solution in cases with negative ultrasound and MRI to detect endometriosis lesions, 7 years of lacking diagnosis?
Yeah, this is exactly the target population. Young women with primary dysmenorrhea with no sign of disease at the ultrasound or the MRI scan. They may have endometriosis, or they have not endometriosis, at least in the 30–40% of the cases. So the test give us as the potential to give us to the patient the opportunity to know, to make the proper diagnosis earlier, to avoid chronic pelvic pain that is much more complicated to manage later in life.
Thank you. The week. The next the week. The next question. The week Indu test should be positive case of adenomyosis and absence of endometriosis.
I don't have information about this because I can't answer properly. Of course, maybe in the population there are also women with adenomyosis and endometriosis that has been positive to the test, at least in the population that has been investigated for the publication that we have. So I guess it's one of the also one of the goal in, as I said before, clustering pain, clustering the disease. Clustering the disease, biological speaking, means also to better identify patients with adenomyosis and endometriosis, or just with endometriosis. This may have far-reaching implications also for treatment, if I think, for example, to conservative surgery.
Thank you. The next question. Well, what about asymptomatic patient with a positive test? Is it acceptable to wait and see, or do we need to treat always?
Asymptomatic, if I understood properly, asymptomatic patients have not to perform the test. Have not to perform the test. This is not a screening for the population. That is a diagnostic tool that has been, investigated in women with symptoms suggestive for endometriosis.
Yeah. Okay, thank you. The next question is for Nicola. Is Nicola aware of the EMPO-WER study? What is your opinion regarding this study? Is it not industry-driven?
I didn't properly
It's
get the
for
question.
Nicola.
Yeah.
Is Nicola aware of the EMPO-WER study?
Empower
The
study.
Empower study. What is your opinion regarding this study? Is it not industry-driven?
Yeah, I mean that's the I think that empowering women, this is if it's about the diagnosis of endometriosis, so making women aware about the disease, making women aware about the diagnosis, it's a major advance. So what is important is there are symptoms, we have to do our job, make a diagnosis. Make a diagnosis means also having the capacity, the intellectual leadership to discuss those symptoms and the results of tests with patient. That's the second step. So awareness about symptoms, ability to make the proper diagnosis, and capacity to discuss diagnosis with our patient in order to provide good answer and to reduce frustration. Endometriosis is associated with a lot of frustration from the clinical, from a clinical perspective, because we are not able to reach the diagnosis when we would like to do. Stage 3, stage 4 diagnosis is not a proper diagnosis of endometriosis. We miss the proper diagnosis, the timely proper diagnosis. So if we have the opportunity to make the diagnosis, but also to develop a new concept of counseling, my perspective is very well welcome.
Thank you. The next question. Is there any difference in sensitivity and specificity in specific ethnic groups with the induced test?
I'm sorry, can you repeat the question, please?
Is there any differences in sensitivity and specificity in specific ethnic groups with the induced test?
Specific, which group, sorry?
Is there any differences
In the phenotype of endometriosis, you mean? Different type of endometriosis, is that the question?
Specific ethnicities. So if the test has different performance in terms of sensitivity and specificity in different ethnic groups.
Ethnic groups, yeah.
Yes.
So that's a very good question. So for the knowledge that we have right now, we are not to answer. Specifically to that question, I can imagine that the test has been evaluated in France, and is currently also evaluated in 18 centers in France and in Switzerland, in some centers in Switzerland as well. Based on the center, most of them are a university center, so their recruitment could be quite, I would say, varied in terms of ethnicity, but no proper evaluation about ethnicity has been performed, at least from a statistical perspective.
Thank you. The next question. Can we use the induced test for follow-up in patients who have already been operated on by laparoscopy for endometriosis? to know if there is a recurrence?
Yeah, that's a very good question. But we are at the very beginning. This is an opportunity. This is a research question. This is for sure will be investigated. But they are at the very beginning. So for the moment, what we have is just a diagnostic tool with a lot of opportunity, I would say.
Thank you. The thanks from Salo Delhi. Thank you very much, Professor Nicola. Nicola, since I come from Nepal, middle income country. How to say saliva testing will take some ages. Professor Sano Delhi.
I don't think so. I don't think so, because if I well understood the mechanism that behind and the process, the technological process that is behind this test, and the reason why they decide to choose saliva, is that the saliva has been already demonstrated that it's very stable for microRNA evaluation, and so this means that at least for the evidence that they already have based on the validation studies where the saliva has been provided thousands of kilometers away from the lab. So results did not change. So we can imagine that saliva is very easy to collect, can be performed by the patient itself. It's just a matter of logistics. But of course, have to be investigated in the future.
That's a question. In your okay, in your experience, what kind of conservative therapy for endometriosis have the best answer for patients resolve the pain for a long time? You have some best measures.
So that's a question that require a fully investigation of the all the factors that are associated with the pelvic pain. So my strategy for chronic pelvic pain is to understand all the situations that are associated, all the pathology that are associated with the pain, and try to address each of them with a proper treatment. But the best strategy to treat chronic pelvic pain is to avoid chronic pelvic pain. And that's the reason why I think the proper management of dysmenorrhea associated with endometriosis or not associated with endometriosis has to be done earlier than we are currently performing in our clinical practice.
Thank you very much. The time is faster, and now 90 minutes nearly come. We have to close the session. Thank you very much for both of you excellent lectures, and thanks for all audience attendance. Give so many very interesting questions and also excellent answers. Now the SGE we have many webinars. The next webinar will hold July 2nd. The name is Endometriosis and Hormone Treatments, Cutting Edge Approaches. I think you, our audience, will waiting for the next webinar. Thank you very much for speakers, audience, and organizer. See you. Good night, good day, good morning. Bye-bye.